Okay, we'll go ahead and get started. I have closed the waiting room so that everybody should be able to just come in. A quick introduction to myself. I am Teresa Larson. I am a researcher for the Transforming Communities Institute, who is co-hosting your event today, which is the USU Social Work mini conference. And that is in collaboration with the USU Social Work Department, who also approves all of our continuing education credits for today's session, or multiple sessions. Throughout the event, we will have multiple presenters, and folks, you are more than welcome to come and go, but you will only receive credits for the sessions that you are actively attending. And as part of that, you will only receive credits if you complete the evaluation, which I will share after each session. So you will get access to that after each session if you do have to go. And before I introduce our presenter, I do want to provide the USU land acknowledgement, as Utah State is a land-grant institution. So as a land-grant institution, Utah State University campuses and centers reside and operate on the territories of the 8 tribes of Utah, who have been living, working, and residing on this land from time immemorial. These tribes are the Confederated Tribes of the Goshute Indians, Navajo Nation, Ute Indian Tribe, Northwestern Band of Shoshone, Paiute Indian Tribe of Utah, San Juan Southern Paiute, Skull Valley Band of Goshute, and White Mesa Band of the Ute Mountain Ute. We acknowledge these lands carry the stories of these nations and their struggles for survival and identity. We recognize elders past and present as peoples who have cared for and continue to care for the land. In offering this land acknowledgement, we affirm Indigenous self-governance history, experiences, and resiliency of the Native people who are still here today. So we thank you all for coming. Just as a reminder, again, if you have come in a little bit late, we are recording these sessions to go on the Transforming Communities Institute YouTube channel. The only thing that is recorded that will be placed online will be the slides of our presenters, as well as the active speaker. So you can keep your camera on and you won't be recorded. You are also able to change the name on your Zoom box, which will help us as we disperse out our continuing education certificates. So if you can ensure that your name matches what you would want on a certificate, that would be very helpful for us. Again, you will have access to our evaluation, which is also required for the certificate. I will make that available at the end of each session. If you have any questions, again, you can put them in the chat. You can do a direct message to me. You can email me if it is about the tech or the certificates. If you do have a question for, at least in this first session with our presenter, you can put those in the chat, and I am willing and will be reading them aloud as we need to, so feel free to put those there. I will now introduce our first presentation, which is Substance Use Disorders, Clinical Intervention and Supervision, being presented by Mike Hanley. Mike is an LCSW and is the Clinical Quality Supervisor at Weber Human Services, where he is responsible for initial and ongoing training and oversight of several evidence-based treatments in the Addiction and Recovery Services Department. Mike currently supervises 11 licensed mental health therapists employed at WHS. With 34 years of clinical experience, Mike has been a field instructor for social work and mental health graduate students from Utah State University, Weber State University, University of Utah, Brigham Young University, and the University of Phoenix. His clinical practice with adults and adolescents has concentrated on treating substance use disorders, providing clinical intervention for victims and perpetrators of domestic violence, and clinical and administrative involvement with outpatient and residential treatment for male clients who have demonstrated sexual behavior problems. So thank you, Mike, and the time is now yours. And if, again, any issues, please email or put them in the chat.
Thank you, Teresa. So I would like to just extend my appreciation for each of you for carving out the time to be a part of this conference as well. I have grown across my years of working in the field to really cherish these opportunities. Oftentimes I am one of the attendees. On occasion, I get to have the opportunity to be a presenter, but I really love this idea that we can get together, consult with one another, hear other people's perspectives, I want to give just a little bit of a preamble in telling you that as I introduce you to some of the clinical intervention and supervision that I do, that it is simply an example. I'm not suggesting that this is the way to do things. I extend appreciation to each of you for the work that you do. I wanted to just say too that we're in the middle of March Madness. Those of you who are directly associated with Utah State University, congratulations on a fabulous season. Um, I followed the team, 5 losses. I know that you play in the semifinal championship game tonight. Good luck with that. Um, okay, let me just share something with you. A Dutch priest and professor whose name is Henry Nouwen made the comment that anyone who willingly enters into the pain of a stranger is truly a remarkable person. And I think nothing better describes the work upon which we embark voluntarily. We're not coerced to do this. We're not ordered to do this, but that it truly is recognized as you're a remarkable person for voluntarily stepping into the pain. We hear the pain. We are witness to the pain day in and day out. The majority of our clients that come into substance use treatment, they are often just disempowered. They are low in self-esteem, a lot of issues going on. So I appreciate again this opportunity to be with you and share with you some ideas that I have and welcome your questions and feedback. So let me start with a quote that I heard not too long ago by Desmond Tutu, that there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. So I think we're committed to both. In our field, we have those who are researching and trying to figure out why is what we're doing working and why is what we're doing not working and how. And then there are those of us who are very committed to pulling people out of the river of substance dependence or the river of really imbalanced mental health dynamics. The objectives that you've received for this particular presentation, I'd like to help you understand the pervasive nature of substance use disorders in the United States and specific to Utah. I'm going to talk a little bit about awareness of effective available treatments. And again, I'm going to introduce you to, if you've not already heard of, you might already be familiar with these, but some treatments that are specifically designed for the substance using population. And then talk a bit about the important role that supervision plays in the development of clinical skill. So let me start with, when we look at physical health and the impact that treatment has had on major illnesses, advancements in the development of treatments that work and the implementation of those treatments have resulted in a significant decrease in mortality rates, you'll see in this slide, in terms of reducing death by stroke, heart disease, AIDS, and acute lymphoblastic leukemia. So on the left side, you'll see at some point between 1965 and 1995 is the point at which these illnesses peaked. Notice the trajectory. As technology improves, as advancements are made, we see that we do have effective treatments and that the results of the implementation of those treatments have significantly changed the trajectory of stroke, AIDS, heart disease, leukemia in terms of death. So we call this sometimes bending the curve, which is another way of saying that if an illness has a mortality rate that's on an upward trend, we have seen physical health that we have been able to change that and move in the opposite direction in terms of reduction of death. Super hopeful, very promising. I wanted to contrast that, if you will, with the data that we have with overdose deaths from opioids. And you can see by these trends that we're not making any strides in the direction that we've seen in terms of physical medical health. We have a 20-year group of data showing us that we're going exactly in the wrong direction. And the question that I would ask you to consider here for a minute is, more people are getting more treatment than ever before. So how is it that more treatment can result in worse outcomes? In the United States, you can see by this chart that we're trending in exactly the wrong direction. Now, the good news is that over the last 3 years here in the state of Utah, those trends have decreased. So that's hopeful. But from a behavioral health perspective, the trajectory is certainly not as promising as what we're seeing regarding some diseases and illnesses in the physical health or medical health trajectory. So I want to talk a little bit about information that I have come across or that I have been exposed to regarding why this might be happening. I had an opportunity in the fall to participate in a summit. We had Dr. Tom Insel come in, and he was the keynote speaker. So in addition to being the author of this book, Healing Our Path from Mental Illness to Mental Health, you can see on the right, a part of his biography is that he was the director of NIH. He has really had a very rich experience as a medical doctor. And well, he was quoted as saying, let me share, quote, "I thought," said Dr. Insel, "that our biggest problem was access to care. Yet there are nearly 700,000 healthcare providers in the United States, more than almost any other specialty. So we have nearly 700,000, more than half being in the traditional psychotherapy professions of social worker, marriage and family therapist, licensed mental health therapist. And you compare that with 209,000 physical therapists or 200,000 dental hygienists. So he said, I thought we needed new treatments, but current treatments are as effective as some of the most widely used medications in medicine. If treatments are effective, why are outcomes so dire?" He said that during his career, which was a 40-year career in medicine, acute lymphoblastic leukemia, the most common cancer in children, has shifted from a 90% fatal to 90% curable. And he said little of this magnificent progress can be attributed to the breakthrough in drugs. Most of it is resulting from learning how to better use the treatments that we already have at hand. So a few things that Dr. Insel shared with us at this summit that was sponsored by Intermountain Health and Weber Human Services. One of them is outcomes are dire not because we don't know what to do or we don't have anything to offer, but because we fail to deliver on what we know and we fail to use what works. I think what I'd like to say too is this is not intended to be an indictment on our cohort or on our community. And it's really good, valuable feedback for us to just be considerate of and curious about. I think everybody that I have ever been in contact with in this field, we are doing the best we can with what we have. I think our intentions are honorable. We come into the field because we have the desire to help. And I just like to remain curious that this isn't because we don't have anything to offer. We have an awful lot to offer, but we're failing to deliver on what we know, and we fail to use what works. Further, he said, we have powerful scientifically proven treatments that are currently used only sporadically. We're not taking advantage of the science that we have. And lastly, our biggest task is putting into practice the many things we have learned are effective, closing the gap between what we know and what we do. So I'm real interested in and committed to, quite passionate about identifying and figuring out what is the gap that we need to close? What is the gap between what we know and what we do? Let me share with you some of the ideas that I have. The first one is, here at Weber Human Services, we have begun to show a 4-minute video introduction to therapy as the clients come in. And on the same day that they complete their paperwork and they complete some screenings, we introduce them to this 4-minute video. What we're committed to doing is getting the right client to the right treatment in the right amount, done well. And what I mean by that is the right client to the right treatment means we have in our junction, in our infrastructure, when a therapist completes an assessment, when they complete a diagnosis, there are evidence-based treatments that are recommended based on diagnosis and symptomology. And at any given point in time, you might see several of those evidence-based treatments populate from which the therapist selects. So the messages that we send in this 4-minute video is that anyone can experience mental illness. We're wanting to normalize and maybe destigmatize the idea that mental illness or addiction is a sign of weakness. So we make very clear in this 4-minute presentation that it's not a sign of weakness, and that the problems really interfere with important parts of life, that oftentimes people lose the things in their life that matter most. And rarely will these symptoms and problems go away without intervention, without treatment. So to salute the client for an act of bravery and courage for coming into treatment. We share with the client that counseling is much more than just talking. So we want for our clients to be very aware that there will be some effort and work required from them. And we present that to them, that they will have between session practice exercises, there will be homework that we might send you home with. But it's going to require more on your part than simply scheduling and coming to a counseling session and doing talk therapy. We also share with the clients that the number and frequency of the counseling appointments that they participate in will in part determine whether or not they fully recover. We encourage them strongly to not discontinue treatment without discussing why with their therapist. Here at Weber, we are big believers in the client autonomy. We believe that the clients are the expert on them. It's really a very positive thing when I can sit with a client and share with them genuinely that I'm relying on your expertise of self. There's nobody who's been with you through every emotion, every thought, every experience. And while you may not remember all of those, you are the expert on you. I'm going to bring my expertise in the field of substance use disorders, and then it will be me and my expertise, you and your expertise against Mr. Methamphetamine or Mr. Heroin. But we'd like to let them know, we're not going to try to persuade you or convince you to not discontinue treatment if that's what you've selected to do. But what we would like to do is at least have the conversation with you about the potential ramifications so that you can make a really informed decision about what this could look like if you chose to discontinue treatment. We want them to be sure to follow the recommended number and the frequency of counseling appointments, and we often use the metaphor of medication. That any of us who've ever known a bacterial infection, we know that we seek out our primary care physician. They may prescribe an antibiotic higher or lower in potency based on what our particular infection is. And then we're given very specific instructions to take 1 or 2 tablets every 4 to 6 hours until the medication is gone. Don't discontinue the medication because the symptoms have subsided. They may very well have subsided exactly because you're taking the medication. And if you discontinue prematurely, the symptoms could resurface. So we like to let the clients know that there will be a number and a frequency. There's a method to the madness here. And we really strongly encourage you to stick to that number. If you have any questions about what we're recommending or what we're doing here, feel free to ask us. We're going to be more than happy. There's research that shows that hearing a message between 5 and 7 times strongly increases the likelihood that the recipient of that message will understand and remember what the message was. So we show that video at the beginning when the clients come in and do their paperwork and complete their intake. And then periodically as treatment progresses, we continue to have this conversation, just reminding clients of that this is not a sign of weakness. To the contrary, it's actually a real indication of bravery and courage on your part that you're here, that it's going to require effort and work, and that there will be a specific number of sessions that we're going to ask you to ensure that you complete. So let me just share with you some of the treatments that we do here at Weber Human Services. They're all evidence-based. What we've done is we've had the purveyors of these particular programs come in, train our staff. Those of us who are on the clinical quality team, we have either flown to a part of the country where we were trained in these, or we've had the expert fly into Weber Human Services and train us so that we might be train the trainer. So initially I'm trained in the model itself, and then I am trained in how to supervise and coach in this particular evidence-based treatment. There's inter-rater reliability exercises that happen as my instruction and my education continues. But so this is specific to the Substance Use Disorder Addiction Recovery Services Department of Weber Human Services. We facilitate the Matrix program. So it's a 16-week intensive outpatient program. We facilitate that in individual and group. And so what I mean by that is the vast majority of the program We have a 16-week relapse prevention group, a 12-week family education group, and a 4-week early recovery skills group. The individual segment of the matrix is that we also do across the 16 weeks, 3 individual / conjoint sessions. Those sessions have their own curriculum. There are very specific handouts specific to the client that's in the room. If the client has a significant other, a supportive friend, anyone who is recovery supportive that they would like to also include, then we have the conjoint session where we provide explanation to that supportive other about what the client's doing in treatment, the rationale behind what we're doing, and how the particular diagnosis is very responsive in positive ways to this particular intervention. So that is one of the things when somebody comes in and they are diagnosed with a substance dependence disorder, then their chart will automatically be flagged, consider the matrix program. If they come in and they have a substance abuse disorder, matrix will not be triggered. So this is a pretty intensive. It starts very intensive at the beginning of the 16 weeks where the client is in 7 hours of group therapy. And by the time they're done with the 16 weeks, they've established a greater degree of stability. Then the client is in 3 hours of group therapy. The second one you'll see is seeking safety. It is facilitated in the group therapy context. So this is a program that's designed for people that have a PTSD and trauma, or PTSD, trauma, and substance use diagnosis. And the work is done simultaneously on both diagnoses. People also are qualified for this particular treatment if they have an anxiety disorder and if it's related to a past trauma history. So they may not meet formal diagnosis for PTSD, but they have some anxiety around their trauma. This particular group is 12 weeks in length. There are 25 different topics, and each of the 25 topics is actually considered to be a safe coping skill. So when the clients come in and they're introduced to whatever the topic is, and oftentimes it's a very empowerment-based group, the clients are really empowered to give decision on what is the topic that would be most relevant for you today. One of the topics, for example, is called asking for help. And not surprising that there are a lot of people who have a trauma history and who have a history of substance dependence who are not real skilled at asking for help or believing that they're even worthy of receiving that help. I've had many clients say to me after I've made an offering of please reach out, let me know if there's something I can do. They will let me know after they may have participated in ongoing substance use or have had a negative event regarding their trauma. They would let me know that they didn't call me because they didn't want to burden me. So I've tried to be real clear and supportive that I really want those clients not to make that decision for me. I would like them to use the safe coping skill of asking for help, reaching out, and letting me be a part of their support network. The most urgent clinical need in the Seeking Safety program is establishing safety first. So some of you may have heard of prolonged exposure therapy or EMDR. Both have proven through the research to be equally as effective in terms of reducing the symptoms of trauma. Seeking safety is kind of a preface to that. Whereas EMDR, prolonged exposure, get into the details of the trauma. Seeking safety keeps it in the here and now. We talk about headlines, not details. And what our purpose is to help provide opportunity and preserve the space for the clients to develop the safe coping skills so that if they then do a deeper dive into their trauma, that when other issues may surface as a result of that work, that they are better prepared and empowered to deal with whatever might come up as they deal in a deeper way with their trauma. CBTSA, cognitive behavioral therapy for substance abuse. We do that in individual and group therapy. We ask all of our therapists during individual therapy in the first 16 weeks to do 10 to 12 CBTSA sessions. This is extensively evaluated in rigorous clinical trials. We know that CBT is effective. It focuses on immediate problems upon entering treatment. And it's a short-term approach. So we've had Brian Killick from the School of Medicine at Yale University come in, train our staff to CBTSA, and then train us as supervisors about how to score sessions when we review them and how to coach to this particular model. The beautiful thing about CBT is that it transcends substance use. So when I'm working with the client in substance use specific treatment, I might introduce them to the skill coping with cravings. And we introduce them to what a craving is. We talk about how they may experience the craving physiologically in their body. We have them identify triggers, talk about coping skills. Well, then maybe 12 weeks down the road, 15 weeks down the road, the client might have completed the course of CBTSA, and I might use that same skill coping with feelings of anxiety. We have refusal skill, refusing opportunities, peer pressure. When you bump into somebody and they pressure you to be a part of substance use, the initial introduction to the refusal skill is in a context of substance use. The next time we might talk about it when a client's telling us about their frustration that they have a partner who insists that they have sex that's not protected, and this client doesn't want to have unprotected sex, doesn't want to risk pregnancy, doesn't want to risk potential sexually transmitted infections. And so we would go through the same CBTSA skill of refusal, but in the context of self-care, taking care of yourself, establishing healthy boundaries. So the thing that I think is real powerful about CBT, very substance use specific, but that the skills all transcend substance use to other issues that the clients might be dealing with. And then, of course, moral recognition therapy, MRT, we facilitate that in the group context. It's a very systematic cognitive behavioral step-by-step treatment strategy designed to enhance self-image, give these clients an opportunity to learn acceptance, get a more productive identity. It's a very powerful group. I've had many clients that I've referred in, and when they first participate in MRT, they don't particularly like it. It's a bit threatening, but the longer they're in the group and the more they're able to pass the steps from steps 1 to step 12, it's very empowering. And they really then, towards the end of treatment, talk about how in some cases the MRT group was the most favorable, most positive experience for them in all of treatment that they experienced. One thing I want to say about these EBPs, we meet as a team. So there are a group of therapists who've been assigned to the Matrix program. There are a group of therapists who've been assigned to Seeking Safety, CBTSA, and MRT. Those groups meet once a month in what we call the Matrix Supervision Group or the Seeking Safety Supervision Group, where we talk detail, rationale of the program, but we also practice. And a part of that is based in a book called Implementation, Practice, and Science, put up by the Active Implementation Research Network. They provide a statistic that says it may take 40 to 50 attempted uses in a practice before that innovation is understood and described well enough to be repeatable and effective in practice. So you might imagine that when we go into role plays and we switch roles, I'll be the therapist, you be the client. We have, sometimes 3 or 4 therapists in that particular supervision group, up to maybe 8 to 10. Everybody takes a turn being in the role of therapist, but it's this idea that very growth mindset oriented here at Weber Human Services. We look forward to the opportunity to make mistakes. We're not worried about making a mistake. We understand that that's going to be a part of the practice. And if I can tolerate the discomfort of making those mistakes, if I can tolerate the discomfort of believing that I'm not a good therapist, it's exactly and precisely what will help me to become proficient and good at what I do. So we do a lot of practicing, trying to give the therapists here actually more than just 40 or 50 attempted uses, but this is something that we do ongoing. So once the therapist gets into one of these supervision groups, for the remainder of their employment at Weber Human Services, it's something that we do once a month to support them and just have an environment that's conducive to learning. And our primary priority is client outcome. We do this. We are willing to deal with the discomfort of the supervision model, but we're all very clear on the reason is because client outcome. So a couple more things that I wanted to share with you. Supervision, how important that is. And I think that probably all of us here place value in this idea of regular meeting up with colleagues to consult, to share the liability regarding our clinical practice. It's highly important that when we are in supervision, that we focus at times on the art and science of clinical care. So there must be those times where we have to focus on the administrative elements, the administrative minutia. That, of course, is equally as important. Not to the exclusion, though, of the idea that to do treatment, there's an art and a science of clinical care. There's a growing body of evidence that therapist effectiveness is enhanced by reflective and deliberate efforts to improve their own competence in practice. And therein comes the willingness and the curiosity about how I can improve my skill. I remember reading from Judith Beck in CBT, where she said when she first started doing CBT, she wasn't very good at it. And then her next line was, but then why would I be? I have never done it. If this is a evidence-based treatment or a treatment that I have never done, I've not been exposed to other than heard about it in a training, why would I expect that I was good at it? But the more I studied, the more I learned, the more I had people model for me what implementation to fidelity looked like. And then the more I practiced, the better I got. So we really strongly want to set an environment here of we support you. I'm going to show you here in a few minutes an example of a video that I send out. It's called a feedback video. I'll explain a bit more about that. But one of the things that we talk about is your openness to coaching, your openness to learning. This idea that I've been a licensed mental health therapist for 34 years, graduated in 1990 with my MSW from BYU. And I mean this sincerely. I heard it before and I've said it before, and the older I get, the more it means to me. The more I know how little I know. I'm not trying to downplay myself. I'm not going to try to discredit myself. I have 34 years of experience, and there's a fair amount of information that I do know. And I want to continue to learn. I want to continue to be a good student. I would say that I am a more hungry student now than I was when I was in graduate school. Because the more I know and the more I learn, the more I know how little I know. And that's very empowering. It's empowering in the context of having a growth mindset to say, I don't have to know everything. I don't have to be an expert in everything. I'm going to bring to the table what I do know. I will make mistakes along the way, but then I'm going to be open to the coaching of my direct supervisor and helping me to become a better coach or a better therapist. So Teresa Moyers, in motivational interviewing, some of you may have heard of her. She's one of the three pillars: William Miller, Stephen Rowling, Teresa Moyers. And Dr. Philip Kendall in CBT, they both discuss this idea that attending a training can improve knowledge and attitude. So if I come to a training on any of these EBPs, I have somebody talk to me about cognitive behavioral therapy or the matrix model. There 100% is in advancement in terms of my knowledge and improvement in my attitude. It makes me hungry to want to learn these. What they have all suggested, however, in the research is that simply reading about or even attending a workshop on an evidence-based treatment is unlikely to be enough to change practice behavior. So what I might learn in a training or in a conference oftentimes doesn't make its way onto the front line between me and a client. But the concern is that the research also showed that participants in the trainings might believe that they now understand that model and can use the new method to fidelity. So they suggest to us for our consideration, and it's here in the middle of the slide, and that is that attending a workshop, sorry, let me come back. Attending a workshop may even inoculate a therapist against further learning because of the illusion that one has already mastered it. Well, we know that learning any new complex skill typically requires really deliberate focus, practice, feedback. They talk about the benefits of even listening to your own sessions. So the last thing here is that staying current with the developments of new and effective treatments really is an ethical responsibility. I had an opportunity to guest lecture at a graduate school, first-year graduate students, MSW at Weber State University last week, and I talked about, for your consideration, when we talk about ethics, that encompasses a whole lot of behavior, one of which is staying current with the development of new and effective treatments is also an ethical responsibility for exactly the reason that Dr. Insel stated. We know what works, and now we have a responsibility to see to it that we are implementing what we know works. So we all expect from our own healthcare providers. I know recently here I had rotator cuff, torn bicep tendon, torn rotator cuff, torn labrum. And I really did have the expectation that the surgeon that would perform this surgery would provide me with the very best treatment. I would not have been comfortable at all had I not had a pre-surgical interview with him and heard exactly what he was going to do. Now, I'm not a medical professional, so I couldn't have told you that what he was going to do was to fidelity. But what I do know is I would have been very uncomfortable for somebody to come into that surgery with me, not knowing exactly what they were going to do, or not having some sort of framework, but just, well, we're just going to take it, play it by ear, and we're just going to do business as usual. And hopefully we'll see something there that we can respond to. So I know what I expect from my mental health care workers, providers, and I believe that our clients, when they come in, downtrodden as they are, going through as much as they're going through, we look at our clients, they are not skill-less, they are skill deficient, and we have an opportunity to really sit with them in a very accepting, non-judgmental way and help them make sense of the experience that they're having. I like to point out that motivational interviewing is one of my loves. I love this idea that just as a doctor doesn't provide the woman with the baby, motivational interviewing is about drawing forth from the client the change talk, the motivation for change, the desire and the confidence that's already in there. Just as a midwife doesn't provide the person with the baby, they simply draw it forth. So we're big on that when the clients come into our rooms, it's sacred ground. We're working in a very diligent way to ensure that when a client comes into We Were Human Services, that regardless of which therapist they're assigned to, and as is true probably with the agencies in which you work, the client is assigned to a therapist based on capacity. So whoever are the therapists that have the openings for intakes on that day are the therapists who get the clients. It should be reliable that regardless of who the client is assigned to, the quality of care, the quality of work will be equally as positive in terms of client outcome. And it's what we're really committed to. Let me share with you one thing here. This is an example, and it's just going to be a few minutes of, so the evidence-based treatments that I do, one of them, like I said, is cognitive behavioral therapy for substance abuse. This is, I have an opportunity, our therapists record a minimum of 8 sessions a month. Those are audio recorded. The clients know in advance. There is informed consent about their involvement in this, just like as we came into this training, we were all informed that the training was going to be recorded. So the clients are aware. Then I have an opportunity to go in and listen to the sessions, and I review them according to the fidelity instruments with which I've been trained by the purveyors of the evidence-based treatments. And I provide feedback to the therapist about the overall quality of the session, about areas of strength in the session, and a couple of ideas of areas for growth that I observed in the session. And when we have that meeting together, then we practice the area for growth. In this last year, we had 9,000 sessions recorded, audio. And of the 9,000 recordings, we had 1,050 of them reviewed by those members of our clinical quality team, providing that feedback to the therapist in relatively quick time, and then sitting with the therapist to practice and help strengthen their skills. So this is an example of the feedback video that our therapists here receive. Hi, good afternoon, Karen. I am forwarding you the. Are you able to hear this? Okay.
Yes.
Review for the CBT essay session that you facilitated with the client on February 2nd. The skill module was Introduction to CBT. It was about a 53-minute session. The overall quality of the session is that it did meet criteria for adherence and competence. You met 9 of the 15 CBTSA specific rating items. And as you know, you must meet 7 in order for the session to be to fidelity. I will tell you also, although not a CBTSA specific rating item, did a fine job of peppering this session with motivational interviewing. So we know that motivational interviewing is just your way of doing everything else that you do. And it was really on beautiful display here in this particular CBTSA session. Let me share with you the strengths of the session, some of them that I observed during this particular treatment session. Coping skill training. You introduced CBT, generally speaking, took a deeper dive into CBTSA specifically. You were careful to cover the 5 key interventions that are attached to the introduction to CBT. So good job on that. In addition, you explained multiple CBT concepts as the discussion developed. You talked about— I'm just going to move this forward a little bit. This session, when the client was unable to really provide a meaningful description or application of the topic or the principle that you were teaching, you were able to provide him with additional information and support in a way that it really preserved his sense of self, as well as provided opportunity for his understanding and learning to increase as well. Future high-risk situations. So after you pose that initial inquiry, inviting this client to anticipate the most potential high-risk situations, including internal triggers, emotional states, or high-risk thoughts that you might have. You ensured that the discussion included helping him identify how he might cope with those challenging situations that he did ultimately identify and that he was likely to encounter during the next week. One idea I have in terms of area for growth, in this particular session, you did provide a new task assignment for this client to work on between sessions. And I invite you to provide a clear rationale for and importance of bringing in the completed written homework to the next session for review. So this particular rating item is distinguished from the new task assignment. Let me pause here for the sake of time. This is an example of the fidelity summary that the therapist receives, as well as the feedback video. And then we take it a step further when we meet in supervision and we actually role play out the areas for growth. It's made very clear to the therapist that also on this same sheet at the bottom, it tells whether the session was adherent and competent. And there's a box right below that that says, did the therapist incorporate feedback from the last supervision session that we were in? And that is the most important box on the whole sheet, in my mind. Is it important that the session met the benchmark for adherence and competence? Of course it is, to some degree, because we're concerned about client outcomes and we're wanting the clients to get the very best treatment possible. Is it important that I highlight the strengths that the therapist demonstrated? Absolutely. And areas for growth, that is the growth mindset. So those are all important. The box I think that's most predictive is the one that says, did the therapist incorporate feedback from the last time we met in supervision? If that's a yes, that's knocking it out of the park. Because it's entirely possible for a session to meet the benchmark for adherence and competence, but for a therapist to month after month after month after month not apply whatever they're being coached to in terms of areas for growth. So those are just some examples of things that we are doing in terms of our supervision at Weber Human Services. I'm not sure if this is going to stop the screen share. I don't get out of this. If it does, I'll come back to it. Let me just share with you lastly, there's a beautiful quote that I came across, one of my, actually, the therapist that I work with, from Gabor Mate, that what we call a disorder is revealed to be an ingenious means for an assaulted psyche to absent itself from agony. It really helped me to look at addiction and substance dependence in an entirely different way. That I've got a client in my office, they continue to relapse for a variety of reasons, but it's a very ingenious means on the behalf of this psyche that has been assaulted over and over and over to absent itself from agony. One thing that I want to make sure that we do not do in psychotherapy or in our therapy sessions is to have in any way how we interact with the client mimic any form of abuse that they've encountered previously in their past. So we're wanting there to be no sarcasm, no confrontation. And I will readily tell you all, I'm a recovering confronter. When I got into the field in 1990, the person that trained me, who is still an esteemed colleague, psychologist, told me, if my clients like me, I'm doing something wrong. You need to be confrontive. You need to be in their face. You need to remind them that you are the expert. Your best thinking got you here, and their best thinking got them here in this very context. And we knew that that was pretty in vogue for our industry, substance use specific, very kind of a confrontive nature. Thankfully, we've learned that that doesn't work, that that is not helpful. And hold gently what the clients give you, because at some point in time, you'll need to let that go. So thank you again. I'll be open to any questions that anybody might have.
I guess I'll ask a confrontational question. How's that, Mike?
Please, thank you.
Okay, so I guess my question is, do you, this is kind of leading way to ask this, but do you believe that we can be confrontational in a way? I remember in grad school, my advisor called it care fronting, in a way that clients still like us and we still preserve that relationship, but that we're bringing things out. I think I get the heart of what you're getting at is, I have a colleague that does peer consultation with me and we talk about all kinds of things. He's in another state, so it's very helpful. But talking about billing, and he wasn't bringing this up. The client wasn't paying their bill and they kept, postponing and all these things, and not having these conversations with them. He's in private practice. Is not beneficial to the client. And so I think what you're saying is don't shy away from those things.
100%.
Yeah, that I think we can still have clients like us, even if we're confronting, if we do it in a way that's sort of therapeutic.
Yes. So I look at it, thank you for that observation. I look at it as confronting an issue, not confronting the person. And
Yeah, I like that.
even use MI to ask permission. So there's a concern that I've observed over the last few weeks, and I want to know, is it okay with you if I share that with you? And then I'm going to talk about balancing support with accountability. You're doing some really, really good work here. A part of your work is actually to be responsible for your bill and to pay that in a timely manner as well. What are your thoughts about that? So I think there's a way that we can 100% confront an issue without the client feeling confronted or assaulted. Yeah.
Yeah, I know. I get worried when you say in your face, because I think I know what you mean, but some other people might not know what you mean. I get
Okay.
more like, hey,
Can I?
I hope that people know, but I think when we encourage that, it's like, well, let's talk about really what that looks like.
Yes. Thank you. Thank you. Because here, what I meant by, and I know our time is short. I remember standing outside of an office of a therapist that worked in the organization with me, and I'm not making more of this. In a loud voice, the therapist was yelling at a man who had been convicted of a sex crime. You are a monster. You are a monster. And I'm thinking that to me is assault of the psyche. It's inappropriate. And it may have been better for that therapist to not be in the field. If this is a population that you choose to not work with, then so be it. But the person that comes into your office who has been charged with a sex crime deserves the same respect, the same demonstration of empathy, support. So how it used to look for me would be this. Excuse me. No, don't forget, I am here because of my best thinking, and your best thinking got you here with a third-degree felony. Don't talk to me that way in the group therapy session. I don't know who you think I am, but I know who I am. That is seriously the kind of thing that we were trained in, which was a very in-your-face, put the client on blast. Why would that person want to come back to treatment? So
Right.
I appreciate you brought that up, because I think there can be a real lag or a misunderstanding between what that even meant or how it looked in a session.
Yeah, and doing it in that therapeutic way, and like you said, discussing, confronting the issue, not the person.
Yes, yes.
Thank you.
You're welcome.
We can take another question. I do want to read, there is a comment in the chat that's not really a question, but you can respond to. Oh, they just added a question to it. Great. So it says, there's a new book receiving attention in the media called Bad Therapy. The author posits, as you similarly did, that mental health outcomes aren't showing similar rates of improvement over time as other physical health outcomes are. Rates of fatality from certain types of cancer have dramatically improved. I don't feel like this gives enough context. How do you connect mental health outcomes to broader societal changes? Examples are easier access to opioid and fentanyl, social media, breakdown of family, etc.
Yeah, I think certainly they're not equal. They're not parallel in the comparison. And I've not heard that book, so I would be really interested in checking that out and being very curious about it. A part of that for me is I'm going to embrace this idea that I'm not going to read the book as an indictment against me. I want to be curious about what the authors are sharing with us or what they're positing. So what we do know is that in the field of medical, physical health, they have treatments that have been robustly researched and they know work, and they're using them. In the field of behavioral health, we have studies and research and models that we know work. There's empirical evidence that supports these do work, and we're not using them. So my concern simply is, if we know what works, if we have evidence-based treatments that have mountains of evidence, and if they have been the studies, the meta-analyses, and we know they're effective, then I would just simply say, I have a really difficult time, because I'm not a medical professional, drawing an equal comparison. But I do think the message for me is, we could follow the medical field in that they are using what they know works, and they're seeing a dramatic decrease in death by certain diseases. We have evidence-based treatments available to us. And I suppose the promise is, if we do those to fidelity, we might see a change in the trajectory. So I don't know if that's responsive to the question or the comment, but I appreciate hearing that. Will you tell me the name of that book again, Teresa?
Yes, it was called Bad Therapy. There was no author attached.
Okay, thank you.
All right. Well, thank you, Mike. If you have further questions for Mike, you all can feel free to email him. He's got his email up there, or ask him a question privately in the chat. But we will go ahead and close out this session.